There is a fine line between acting in the patient's best interest and depriving them of their civil liberties. One of the greatest ethical dilemmas that paramedics face is determining the validity of a patient's right to refusal or whether other means are necessary to achieve a safe and acceptable outcome. This case study will investigate the speculation surrounding Ezra's decision and whether it was acceptable by addressing the required provisions to enact an EEA, what defines a mental illness, and a person's capacity to consent with relevance to the person's age. An Emergency Examination Authority, or EEA, allows for the temporary detention and transport of a person to a treatment or care facility in circumstances where the person is acting in a manner that is indicative of a major disturbance in the person's mental capacity, rendering themselves or others at immediate risk of serious harm. EEAs do not require the patient's consent, thus depriving them of their liberty, and can be implemented by paramedics and police if the following criteria are met. The person's behaviour indicates an immediate risk of serious harm, and the risk appears to be related to a person's mental capacity, and the person appears to require urgent examination or treatment and care for the disturbance. In addition to this, there must be no less restrictive way for a person to receive treatment and care if, for example, instead of being detained involuntarily, the person is able to receive the necessary care at home. Under Section 10 of the Queensland Mental Health Act 2016, a mental illness is a condition characterised by a clinically significant disturbance of thought, mood, perception, or memory. A person cannot be considered mentally ill merely because of factors related to their belief, opinion, status, disability, substance-induced behaviours, sexual orientation, or misconduct. As a component of their mental status assessment, Ezra and Prakash should have determined whether there were any clinically significant disturbances to Odessa's thought, mood, perception, or memory. From this case study, it was found that regarding thought, although Odessa was presenting with some compulsion to complete her errand despite the situation, this was not found to be clinically significant and will be discussed further. In regards to mood, no immediate disturbance to mood was present, although it was unclear whether her emotions were congruent with the stressful situation. In regards to perception, no subjective indicators of hallucinations, illusions, derealization, or depersonalization were present. In regards to memory, no clinically significant losses in acute or long-term memory loss, as Odessa was able to recall events and was oriented to time and place following the administration of oral glucose. From this, it was determined that at the time of the EEA, Odessa was not mentally ill. Section 14 of the Mental Health Act 2016 states that a person has capacity to consent to be treated if the person is capable of fully understanding the nature of their illness, the benefits of treatment, as well as the risks and consequences of not receiving it, has the capacity to decide about their treatment, and is able to communicate the decision in some way. In distinguishing between capacity and mental illness, the presence of a clinically significant disturbance of thought, mood, perception, or memory would indicate that a person would not fulfill the criteria for possessing the capacity to consent to or decline treatment. It is also noted that a person may have capacity to give medical consent even though the person decides not to receive treatment. It is also important to recognize the transient nature of capacity which may be affected by the temporary mental states such as intoxication, shock, fatigue, and other chronic disorders, which may induce an altered level of consciousness. In severe cases of diabetes and hypoglycemic episodes can induce delirium and psychosis. However, because Odessa was treated and her condition had improved, Odessa is said to have had full mental capacity at the time of the EEA. To determine the validity of Odessa's refusal, the Verker assessment will be applied. It must be voluntary, informed, relevant, she must have capacity, and advice must be given. In regards to voluntary, Odessa's decision to refuse transport to hospital was found to be voluntary in that it was free from coercion or influence from other persons. In regards to informity, Odessa is aware that she has insulin-dependent diabetes and is responsible for maintaining her blood glucose levels with insulin therapy. It is entirely possible that Odessa did not fully realize the consequences of a hypoglycemic episode, as her diagnosis is still relatively recent. This point is evidenced by her decision to operate a motor vehicle immediately after inappropriately administering her insulin, indicating that she did not understand the effect that it would have on her ability to drive. Her desire to continue her errands and forego further treatment indicates that she still lacks a level of knowledge and insight to satisfy the requirement for her to make an informed decision. In regards to relevance, Odessa's refusal was relevant to the recommendation of transport and further treatment. In regards to capacity, medical professionals need to identify whether the patient can form a sound and reasoned judgment by determining the patient's maturity and intelligence, their understanding of the treatment and risks of not receiving the treatment, and their understanding of why the intervention is required and what is involved. The same standards can be applied to assess the capacity of a minor through the use of Gillett competency principles with emphasis on assessing the person's maturity. This stance is also agreed upon by Legal Aid Queensland, who state that generally patients over the age of 16 are assumed to have capacity. It was found that Odessa was able to understand that she had an illness, the nature of the treatment, alternatives to treatment, and was able to make and communicate her decision. However, it was noted that there was little evidence of her being aware of the risks associated with receiving or refusing treatment, which reflects more on her lack of information rather than her capacity. Provided Odessa is no longer confused and is of sound mind at the time of the paramedics explaining the situation of the treatment versus no treatment, it is assumed that Odessa has capacity. Had Ezra implemented this assessment, he would have found that Odessa's refusal was valid. If Odessa's refusal had been recognized as valid, Ezra and Prakash would have needed to provide advice regarding the alternative management of her condition. This point will also highlight the inappropriateness of Ezra's use of the EEA. As discussed earlier, one of the components of involuntary assessment is that there must be no less restrictive way. As opposed to abusing the use of an EEA, Ezra and Prakash could have proceeded to follow several less restrictive courses of action, including waiting for the tow truck with Odessa while continuing monitoring, thereby ensuring her safety over the duration of the situation, contacting a friend or family member to come and take care of her, having the police issue an infringement for negligent driving. And it can therefore be concluded that Ezra's decision to transport Odessa under an EEA was inappropriate for the situation and did not align with the current policies. After initial stabilization, it was found that Odessa was not mentally ill and possessed the capacity to decline treatment. As a result, it is possible that Ezra could be held accountable legally by the QAS or APRA and/or pursued through civil courts.